TopMedTalk.
Hello, and welcome to TopMedTalk. I'm Desiree, Chappell, lead anchor for TopMedTalk, and we are covering the COVID-19 pandemic from the front lines. Our conversations in the past weeks have spanned the globe, and we will continue to bring the latest updates as long as we can before we're called back into action. Now, I'm joined by our editor-in-chief from London, England, my partner in crime, my wingman, Monty Mythen. Hello, Monty.
Thanks, Desiree.
Well,
How are you?
I'm doing okay. I've been missing you a little bit, I know things are a little crazy over there for you. You've been feeling a little bit under the weather, and other years you would have probably just knocked it off to being, having a cold, having a little bit of the sniffles. But right now with the COVID crisis, this is a real possibility. So you decided that you were going to go in and get tested a couple of days ago, I guess within 48 hours. And so let's have the big reveal. Are you positive or negative for COVID?
Yeah, so I'm no surprises. I'm COVID-19 positive because as my, going around at work is, if it looks like a duck and it smells like a duck and it walks like a duck, it's probably a duck. So the mild signs, relatively mild signs and symptoms I had at the present day, it's spring, the sun is out. One has to assume until proven otherwise that it's COVID-19, and indeed it is. Now, I was able to get that selected test because as a frontline healthcare worker, we will try and determine of people who are symptomatic, who are looking at when they can return to work, whether it is a mild head cold, which is extremely unlikely now, or COVID-19, and it's COVID-19. So I'm quarantined, carrying on my quarantine now.
Right. Working from home. How long will you be quarantined, Monty?
So it's 14 days in total. Now, when did it start is the question with that, because there's a likely period. So, I've been self-isolating this is end of week 3 for me now. So I've been self-isolating in anticipation of joining the frontline workers and working from home and being an early adopter led by my public health colleagues of trying to work entirely off my laptop using different platforms to communicate in isolation. You could then ask how I think I got it, but that's what I was just going to ask that. We'll come back to that in a second. This all is a great explanation, I think, of why this idea of self-isolating as a family is so important. We're going to work on the basis that I'm about 5 days into it. So if we go for the 14-day strong self-isolation, the advice from work at the moment is let's review the situation where you're completely symptom-free for 3 days, and we'll take a view then. Mm-hmm. So we'll see when that happens, because many people have had it. There is a lingering period of ongoing fevers, and it doesn't really count as being completely symptom-free until you haven't taken any acetaminophen, Tylenol, paracetamol, whatever you want to call it, to modify your signs and symptoms.
Right.
So you've probably got at least another week of me if I stay well.
Yeah, yes, of course. And now that you're feeling, you look a little bit perkier than what you were a couple days ago.
I think this is the best I've felt since Monday. And last night was the best night of sleep I've had since last Monday night.
Yeah. So Monty, you are you could be a frontline healthcare worker. You've been in critical care. But the question is, have you been working on the front lines recently? And do you think that's where you contracted COVID?
No. So as I said, I chose to self-isolate because I was able to, on the nature of the way that our rota was coming through, because I volunteered to rejoin critical care. So they said, when are you available from? And I said I was available from the 1st of April, and then went for the self-isolation approach to try and stay well leading up to that point. I was also getting quite frustrated with people who were continuing to travel in and out in London, for example, in and out on the tube to go to meetings that really didn't need to be face-to-face meetings, and therefore effectively accelerating the spread of COVID-19. Now, people would say to me, well, hang on a second, you stayed at home and you've got COVID-19. So no, that's not the point. I'm here with my immediate family who've been self-isolating, and on a balance of probabilities with 2 students, one at school, my wife who works at a school that closed relatively recently. On a balance of probabilities, I got it from them. Mm-hmm. So, that's much more likely that asymptomatic school children and students have brought it home and given it to me, as opposed to me, who hasn't been anywhere near, has given it to them. However, if I had been to work, there's no doubt that they'd be badging me as the source of the infection. This is a very important learning point for everybody, because it's not about you getting it, it's about you giving it. So if I had been going in and out to work, I would have been contributing to that equation that Hugh Montgomery describes so eloquently, is that if I give it to one person, I might as well have given it to 50,000 people. Yeah. Now, sadly, we might be seeing the inevitable results of that manifesting itself in our political leaders. Our Prime Minister has just been tested COVID-19 positive. Our Health Secretary, Matt Hancock, has just been tested COVID-19 positive, or at least he's got mild symptoms and they're self-isolating. They're likely been contaminating each other since they gathered in Parliament and announced the first of their colleagues that was off work COVID-19 positive. That was probably their contagion rapid spread moment, where they gifted it to each other. And with lots of understandable public criticism, continued to engage in face-to-face meetings. I can understand why they did it, because none of us have been through an epidemic before. I think we'll behave very, very, very differently the next time. Yeah. Sorry, a little bit of a speech there, but, it's important. It's hard for us to get our heads around to say, well, you stayed at home, you've got it.
Yeah, it is. And then you kind of think, well, the cat's already out of the bag, so what does it matter at this point? But I think it still matters, don't you?
Well, it matters enormously. And sadly, I think we may have missed our opportunity in London, but there's lots of opportunities for healthcare systems elsewhere that haven't got there yet. Is we have, I hope, blunted the curve on the patients. There's still going to be a lot coming through, but I don't think we blunted the curve on our colleagues, because I think during the period of contagion, people are continuing to gather in packed rooms and do handovers. And, there's tweets and pictures up every day of the week of people not self-isolating at work and or continuing to go to work for meetings they do not need to be there. Real leadership now is not walking the floors. Real leadership now is being seen and heard clearly on your laptop, communicating from home. So it is no longer clever and saying, well, I'm a great leader because I'm seen at work. Great leadership now is protecting yourself so you can continue to be a great leader. There's a reason Winston Churchill took to the deeper bunkers when it got serious. He didn't take to the turrets. Yeah,
that's a great point. And I think that for healthcare workers, I mean, it's hard because you go into your hospital and you think, I mean, you're not thinking like, oh, I have this magical bubble around me. Everybody's there contagious, but it's tough because you're still trying to do things like I always do, taking care of patients. And that involves close quarters and those meetings and the break room and the cafeteria and everything. But in reality, that's probably going to be, something that is a downfall. I know that there are a lot of facilities, at least here in the U.S., that are not mandating that people wear, surgical masks to prevent spread within the hospital outside of the OR. I mean, what do you think about that, Monty?
I think now is the moment. I mean, we have sometimes laughed at our colleagues who've experienced serious viral outbreaks in other parts of the world about their persistence in the wearing of surgical masks in public. Now, I think in the future, either we will A, be doing that ourselves much more commonly, or B, will be applauding them for their contribution to society and foresight. Because the surgical mask is not there to protect you, it's to protect others. Mm-hmm. It doesn't protect or filter that much of the air in the way out, but it does reduce the spray that inevitably comes as you speak. So I'm speaking now, and in front of me is my computer, and for probably as far as my windows, which are up to 3 feet away, there'll be droplets hitting it as I get more animate with my speech. That's why they're wearing those masks. And it was interesting, I said, we both watched, I think, a webinar, which we'll put a link in, from the European Society of Anesthesia. Well played to them that the speakers in Italy and in China and in Germany were wearing surgical masks, even though they were on a webinar on their computer in the isolation of their own office. That is A, good from the point of view of not contaminating the keyboard for the next person, which they're going to wipe down afterwards, but, reduce the spray load. But also the symbolism of it is important.
Mm-hmm. Lastly, while we're talking about your battle with COVID-19, what have been some of the signs and symptoms? How did you notice it kind of coming on? What were some of those very, very early symptoms to some of the worst things that you've been experiencing?
So first thing to note is I was symptomatic. So I had what typically people would wave off as being a mild cold. I had a little bit of a runny nose, a little bit of a sore throat. I did not of note have a cough, and I did not of note have a high fever. Now, as we look back at all of the data from Wuhan coming forward, anything you can think of is on the list of signs and symptoms of COVID-19, including absolutely nothing, e.g. asymptomatic. The first tipping point for me, my first oh no moment, was last Monday night when in the middle of the night I had rigors. So rigors being that feeling you get with flu, such that you feel very, very cold and are shivering and at the same time sweating, even though when you measure your temperature, it's elevated. So mine was up around 38. You'll have to translate that into Fahrenheit. And at the same time, that first night, really horrific nightmares, very, very, very vivid nightmares that have been described. The following day, just muscle aches and feeling weak. And then remarkably, a bit like it's time programmed, at about X o'clock, the fever came back again, you get a little bit muscle achy, and then the following night, a similar cycle. And then so it was the third night of that I arranged to get tested because I thought, well, I've got COVID-19 now, until proven otherwise. And the reason I needed the test is because if I didn't have COVID-19, I could go back into the workplace more quickly. There's no different treatment to be done. There's no different behavior patterns because we should all be self-isolating anyway. So, we at home have all assumed that the others have got it. So it doesn't suddenly mean that now Dad's been diagnosed that everyone has to behave differently. Yeah. We behave the same as we were before. Yeah. The difference is I can't go back to work for another week. And if I'd been tested negative, I could go back to work as soon as I feel well.
So Monty, whenever we, in the past several weeks, have been doing screenings for patients or just anyone, to determine whether or not they have COVID or not before we could rapidly test and have access to the test. Do you think it was the right thing to be screening patients for fever, cough, and if you've traveled to Italy or China?
So I'm no expert on this. I think I'm becoming rapidly a sort of amateur enthusiast. But our public health experts who deal with epidemics or have dealt with epidemics or more educated on a more regular basis would say absolutely yes. Screen, test, isolate, source isolate, understand, control, which I think our colleagues in countries that have this is more familiar to them did much more effectively and much more quickly. Now, when we get through all of this, which we will, as I said, I think we will behave very differently the next time.
Yeah, absolutely. Lots of lessons to be learned through this entire process.
We won't be laughing it off next time.
No. It won't be a hoax or a
conspiracy or whatever it is. But
yeah, for sure. Before we go, there are Slido questions. We're getting Slido questions and then questions emailed into us.
Great.
Can we take those Slido questions real quick and just knock those off?
Sure.
There we go. Monty, I think I know this answer. Is your facility canceling elective cases? And if they are, when did they stop?
Oh, I've lost track now. It was ages ago. So they've for the majority of places locked down a number of weeks ago now.
Did the entire country lock down?
No,
or was it facility by facility?
So now, when I say that, there are still in certain pockets of bespoke hospitals, there is some scheduled cancer surgery going on, but I know I've had a little bit of virus in between, but I'm losing track of how long ago elective cases stopped in pretty much everywhere.
Mm-hmm. Last week, the facilities where I cover stopped
Yeah.
By the end of the week.
Yeah.
So.
I think everyone's there now. I can't be amazed if anyone's still doing elective cases.
I think there are actually still some elective cases going on in remote areas of the U.S.
There are different circumstances, different places.
Yeah. This is from Joe Chapman, a CRNA from Duke. Hey, Monty, in the ventilator count, are anesthesia machines considered?
Yes, they have been in our initial evaluation of how many ventilated patients we could cope with for our surge plan. We have, to be fair extent, as warned up front, that they are not a longer term solution.
No.
Most of the anesthetic machines are quite appropriately designed to be attended, and they have a sort of timeout requirement over a number of hours to have certain things change. It's all highly appropriate for what they're designed for. It's fantastic machines. They're a great stopgap, but we are rapidly trying to replace them. If their purpose is to be used as a ventilator for a critically ill patient, with purpose-built ITU machines, ventilator machines, hence the sort of Dyson type of story that let's make a lot of ventilators that are designed for this purpose.
Yeah, and they are rapidly going to be able to produce those and get those out, aren't they?
Now the guts, the wonderful ventilators are anesthetic machines, but they've understandably had a lot of checks and measures built into them to stop them being easily adapted to this purpose. Now, people could spend a lot of energy trying to unadapt them, but we're going to need our anesthetic machines again soon. So I think the better thing is to get them replaced with ventilators. Having said that, we're actually seeing massive growth in our use of so-called CPAP, continuous positive airway pressure, which is a much simpler device. And it seems as though a large number of patients can avoid intubation and mechanical ventilation by going down the CPAP route. And we've got a number of descriptions of that on TopMedTalk podcasts.
We do, yeah. We first started hearing CPAP and early intervention with that versus ventilation out of Italy.
Yep.
For numerous different reasons, but hopefully that it's preventing intubation and escalation. So we will be putting out a series on just CPAPing here, hopefully in the next couple days. Our next question is from Emmanuel Staphylarchus, and I'm sorry if I mispronounced that. Dear Professor, in exposure with COVID-19 overdose and ACE2 receptors overpassing, is there any similarity with ACE inhibitors side effects?
A great question. So I'm assuming you're extrapolating from the fact that when you take an ACE inhibitor, one of the side effects you can get is breathing problems and a persistent cough. Now, they don't think that that's the same link, because it's the ACE2 receptor that's in play here. Now, this is going to be a much longer conversation, and I think we're overdue having a special series on the ACE genotype and the ACE relevance and ACE inhibitors. There is general guidance that stopping ACE and ARBs is not necessary in the face of COVID-19. Whether specific ACE2 receptor antagonists, which have been developed in the past and have got as far as early phase trials, will come forth for clinical use is a known unknown at the moment. But our colleague, Professor Hugh Montgomery, is a world expert on this, who's been interviewed on TopMedTalk recently, and we'll try and get Hugh for a special, longer update on the ACE receptors and COVID-19. So forgive me if I can't give you an expert answer over and above that, but Hugh can.
Our next question is from Julian Fuller, who is from Auckland, New Zealand. We await the tsunami in New Zealand and Auckland. With no ICU cases yet and only 5 hospitalized cases, would be good to know numbers for admissions, IPPV, et cetera, in the UK critical care.
So I think, Julian, if you just keep up with everything that's being advertised daily, almost hourly, coming out from the UK and the other European centres that have been hit by COVID-19 so far, that will give you a much better idea. The dramatic version of it is you cannot over-prepare to be able to look after patients who need breathing support. So the Italian extreme version of it was 700-bedded hospital with 500 patients needed support. We're geared up for a high level of support in the first instance up to within our own acute units to go up to about 80 or 90 cases. But at the same time, we're building a allegedly 4,000-bedded urgent care centre that would have many thousands of ventilated patients being able to be taken at the Excel Centre in the East End of London called the Nightingale Hospital. Whether it will ultimately manifest itself that way, but, if it's coming, prepare for the worst and hope for the best.
Yeah, absolutely. But I think one of the misconceptions about this whole thing, is the death rate versus the rate of people flooding our critical care in our hospital system. So, I mean, we still, there are a lot of people dying, but there are so many more that are, this huge spike of people coming into the hospitals that have critical care needs, and they're just not going to be able to be met. I think in New York City alone, there are 800 people in one day that needed an ICU bed. So that's where the spike is, and that's what we're trying to flatten is the need.
I think what's really important in this conversation, again, we'll get some experts back in, but you can get it from our early podcasts from Bergamo in Italy, and the conversations with our colleagues preparing in the USA was, as opposed to concentrating everything on being able to intubate and ventilate, is to gear up your ability to be able to deliver the intermediate respiratory support. So we are massively increasing our capabilities within our hospital to do more CPAP. My colleague there, who was looking after the patients for the last few days, is saying how wonderful it is to be able to do a ward round, which in the patients who are on CPAP can give you the thumbs up as a sign to say, this is working for me, doc. It's great if we can keep it at that level. I'm not saying it's the right thing to do, but we need to keep having that conversation, because if we over gear up for intubation and ventilation and we keep pushing people down that track, we may have rushed them down that track too soon.
Yeah, it might not be the right answer.
More on that every day.
Absolutely. Well, Monty, I'm glad to see you looking so well. And I'm glad to hear you sounding so well.
You're a great liar, Desiree.
Well, you look better than you did look the last 3 days. I had to tell you.
Great radio face.
Podcasting face. A great podcasting face.
It is interesting how well you can feel compared to the nighttime. For my last few days, for a number of hours of the days, it gives you this real false sense of wellness for a period of time. Yeah. And then it hits you. Man, it hits you hard when it hits you.
I've seen it. I've watched you. The day as we talk, we're doing all of our conversations by Zoom. You look well on it.
Didn't I?
You did. Yeah. You shared your thermometer readings, but I could see you look really great. And then by the evening, you were fading. So I hope that you stay well and that you've seen the worst of it. We all hope that for you. And let us know. Keep us updated on that front.
TopMedTalk.
Thank you to all of our guests that have been contributing. Thank you to our sponsor, Edward Life Sciences, for this continuous coverage of COVID-19 from the front lines. And thank you for listening.